2 hours, shouldn't keep you here too long or anything. But I do have a wee quiz to start. We'll do that in about 10 minutes. Then we've got Rachel Darcy-Campbell. She is an MS specialist neuropharmacist. And we have Amy here as well from the MS Society speaking too. So yeah, I might just wait a few more minutes just as I've got a lot of people joining. Yeah. So in case you don't know me, I'm Joanna. I'm a second year at RGU and I'm the BPSA's Northern Area Coordinator. So thank you to everyone for coming today. This event has been in the making for a while and I'm very glad that it's finally here. I started my BPSA journey as a representative last year, which got me to where I am today. So I worked really closely with the previous Northern Area Coordinator, who's Kelsey. She is here, who's now Secretary General. The jump from being a representative to being an area coordinator is quite a big one, but I thought this year I could do the role justice. And I thought, what a better year than this one to get involved, especially with COVID. So multiple sclerosis is my topic of choice because I've seen it firsthand within my family. And the support that we can give as pharmacists could extremely help someone who's suffering with MS. I feel a lot of people don't know enough about it. So my hope is that you take something away from today and you enjoy the event. So to put it quite simply, my gran has MS. She was diagnosed at the age of 40, and at that point, she really wasn't that bad. She was able, so this is from my kind of youngest memories of her, she would go on walks with kind of... Someone keeps muting me. Sorry, that was a bit random. So yeah, from my youngest memories, she was really able. She would be able to go on walks with a stick that you would use for kind of hiking. She lives up north, so we did do a lot of like hill walking kind of things like that. She would cook every meal. She'd be baking bread. She'd be baking cakes. But the biggest thing was that she could drive. Now, my gran can't drive now. I feel that was the biggest change for her, especially living up north in this kind of isolated village. Driving is a major thing. So I'm not sure what you already know kind of about MS, but I feel a common misconception there is that it is only kind of mobility issues. I can't emphasize enough how wrong this actually is. Sorry, I'm still admitting people. So yeah, from a young age, my gran kind of had bladder issues and had to get a stoma bag fitted. Her heart can't keep a regular rhythm, so she was fitted from a pacemaker. And the biggest thing is her memory, quite honestly. Currently, it's only her short-term memory that is kind of affected. She can't remember what she had for dinner last night or what carer came around this morning. But she can remember that when I was 2 years old, I stayed with her and had the chicken pox. It's funny because she'll remember memories from a very long time ago that I sometimes forget existed. But it's something as simple as, who came round to see me earlier? That can be something she won't remember. So yeah, my granda passed away a year and a half ago. This really kind of brought her to pieces and she really struggled. So every morning kind of after he first passed away, it'd be, where's Billy? And we have to keep reminding her that he did pass away and she'd ask where he was. And it's quite hard as well for us who are grieving to keep telling her, but he's passed away. So this is obviously a really big kind of mental thing. Sorry, that was my buzzer to my flat. I'm currently at home. So yeah, it's a really big kind of thing that a lot of people don't see kind of behind the scenes. COVID has been a big thing. The only person my gran would see every day are her carers. She sees one in the morning and one at night. And because she lives in this isolated village, the only person that does live nearby is my auntie. So although she could see my auntie, it would be from the window, and waving from the window as the only persons that could come in during COVID are the carers. So nowadays, my gran isn't the fittest woman. She can't drive, she struggles to walk. Whenever we're out the house, she's in a wheelchair, she has her own wheelchair, we push her about. So it is something that can affect a lot of things. And if you don't know that, I think it's important that we learn about it and learn how we can support. So my main aim is, there's more to MS than meets the eye, and this is what I want to get you to see today. So I have a wee quiz. I was going to do it on a website, but I think we actually have too many people. No, do you know, it'll be fine. Hold on. I'm just going to screen share. If you all have a mobile phone or something similar, you'll need to put the wee code in. Let's share. Can everyone see my screen? I'm going to assume that that's okay. Sorry. So yeah, I'm just going to start this. Is there a code somewhere? If you put the code that's just up the top here and in your mobile device and slido.com, it'll kind of start the quiz. I'm just going to check if we're having any issues. If you just put in the chat if you're having kind of any issues or anything like that. Oh, that didn't work. Hold on. Do you know what? I think I'm just going to stop doing this and we'll just do it on Zoom instead, because it's not really wanting to play. Sorry about that. So I've just got some polls that I'm going to put up. So if I just launch the first poll. Can everyone see this okay? Okay, brilliant. So my aim here is just to give you a rough idea, kind of the statistics of MS and what's kind of involved. So yes, I'm hoping, can you see all the questions or is it just the one? Oh, I'll have to announce the results for each one. Okay. Thanks, Kelsey. Is it working? Yeah, there we go, that's fine. I'm just going to give you just a minute or two just to kind of go through them, just because there's quite a few questions. Perfect. So just in a couple of minutes, I will reveal the answers. So there's just a few more votes to come in if anybody's still to vote. So I'm just going to end the poll now. Just if anybody's left to vote, I'm just going to end it and we'll just go through the answers. So, sorry, I'm not used to using polls like this on Zoom. Takes some getting used to. So my first question was, how many people in the UK, roughly, give or take, have MS? So believe it or not, 130,000 people do have MS. So that's quite the statistic. If I could get the words out, that would be good.
Wow.
Yeah, it's a lot of people. You wouldn't realise how many do have it. Sorry, my computer's not wanting to play just now. 2 wee seconds, just as I sort this out. There we go. 130,000 in the UK have MS, yes. So quite a lot of people do. And then my next question was, how many people are roughly diagnosed each week? So that is 100 people. It might not seem like a lot of people, but think about roughly the amount of people on this call getting diagnosed in the UK each week. So this can be like a life-changing thing to find out. So it can really make a big difference. And the next one was, is MS curable? It's not curable. There's treatments we can do to manage it, but there's no cure as of yet, because it's all to do with your nerves and your brain. It's not that simple and it's not really easily understood. So there are 4 types of MS. I'm not going to go into too much detail of them, but there are 4 different types. And this is more common in women. Yeah, sorry, I thought I got a question there. There's not too much to it, but the prevalence is a lot more common in women than it is in men. Sorry, my computer's still not wanting to play. I'm just trying to go with it here. So out of all the continents in the world, it's actually more prominent in kind of areas like North America and in Europe, more commonly in kind of Canada and Scotland than it is in other places. Now, this was kind of a shock to me. I didn't know this was a thing. It seems like a really random fact, but it is in fact true. I don't have any slides with the questions. The questions are just on the poll, but I can make up a document and I'll send it out after to everyone that's registered. So yes, I think you can see the poll results there. There we go. I didn't realise I could do that. See, if I knew I could do that, I would have just done that in the first place. Not very good at this. So yeah, you can see the kind of results there now. I didn't realise that you could do that. Yeah, so maybe I'll kind of just stop going through them then. If everyone can see them, that'll be a bit easier then. Sorry. So yeah, there's a good few kind of things that give you an insight to kind of MS there that you probably wouldn't have realised before, just to kind of open your mind before you kind of go into the session. I'll give a minute just to go through because there is 10 questions there. Okay, so apparently it doesn't show the answers, it just shows the most popular ones. So I'm just gonna, sorry, not really planned for this, didn't really realise, but that's okay. So on average, the cost of someone with MS in the UK with only mild disability is about £11,000. So that is a lot of money just to have like a mild disability and not anything major. Yes, I'll just keep going through the rest of the answers just so we don't get confused between the ones that were there before. So a bit more kind of pharmacy based. Which of these medicines can be used for MS? So out of the answers we had there were diazepam, baclofen, amitriptyline, amoxicillin, and candesartan. So your right ones are diazepam, baclofen, and amitriptyline. I won't go too much into that, mostly just because diazepam for your back spasms, amitriptyline for any nerve pain, and baclofen is almost kind of like for MS and osteoporosis. Question 9, all of the symptoms I put down, every single one of them is a symptom of MS. It can almost affect absolutely everything, honestly. If you have a wee look on the NHS website, there is so many different things that it can affect that you wouldn't have realised. So, and how is MS diagnosed? So that is through all of them, through an MRI scan, through a blood test that will rule other things out, through a neurological exam. Every single one of them can be a diagnosis of MS. So yeah, I hope that gave you a wee insight just into MS before we start. And I'm just going to hand over to neuropharmacist Rachel Dorsey Campbell. So thank you very much for coming today. And yeah, I hope you enjoy.
Hello, everybody. So well done, Joanna. That's fantastic. I didn't know Zoom could do polls, so I've learned something today that I will be a bit of CPD for me. I've been learning how to do those. Right, and I'm also a bit, I'm not very good with Zoom, and I'm just trying to work out how to share my screen. Bear with me 1 second. There we go.
I've just made you a co-host, so you should.
Okay, so I should be sharing.
That's you.
Yeah. Great, so you can see that, yeah? Super. Okay, hello everybody. I am Rachel Dorsey Campbell, and I am a pharmacist working in Imperial, and Joanna's asked me to present to you today on MS. She's just given you a really good insight into what it's like having MS, having a relative herself. She's got some good understanding there of how it affects people. And I'm going to go over some other details for you about how we treat it. So I am the senior lead pharmacist at Imperial College, which is in West London. That is the lovely 1970s tower block that I work in every day. I'm a non-medical prescriber working in a neurosciences team, and my day-to-day job is mainly taken up with MS and looking after people with MS. We're a big centre. We have about 4,000 people on our books with MS, and we have about 1,400 of those on disease-modifying therapies. So I've been a hospital pharmacist all my career, and I actually did my pre-reg, I won't tell you how long ago, but a long time ago. And I've been working at Charing Cross pretty much since then. In neurology probably for the past 16, 17 years. So what we're going to cover in the next half an hour or so is a bit about what MS is, who gets it, what's thought to cause it, a little bit about the 4 different types that Joanna's mentioned. I'm going to talk a bit about how it's diagnosed and how it first presents. And then we're going to go through some of the treatment options that people have. And I'm going to spend a little time at the end talking about the important bit, which is the role of the pharmacist in all of that. Okay, so what is MS? MS stands for multiple sclerosis, which is multiple episodes of inflammation or scarring, and that's the sclerosis part. And those the scarring lesions occur within the central nervous system. And so that's episodes of inflammation within the brain and spinal cord that then cause areas of scarring. And because the brain and spinal cord, obviously the nerves coming from the brain and spinal cord then can go to any part of the body, as Joanna says, the effects are therefore really widespread, and it can affect huge different areas of the body, and we'll go through those. In order to get diagnosed with MS, you have to have more than one episode separated in time, and also in different parts of the central nervous system. And it is an autoimmune disease. So this is a neuron, and you can see there's a fatty white sheath along the length of the neuron called the myelin sheath. So that's a fatty substance, myelin, which coats the axon of the neurons. It's produced by cells called oligodendrocytes, and it insulates the axons, and it makes the transmission of the nerves more efficient. So it's a bit like the plastic insulation on an electric wire. It helps the electric message get along the nerve much easier. In MS, that myelin sheath is damaged, And by damaging the myelin, you interrupt the flow of the message traveling along the nerve, and you lose the efficiency of that nerve. And that presents itself as a loss of either sensation, feelings, or function in terms of movement. Why does that happen? Well, it's an autoimmune condition. So your immune system in MS is attacking that myelin sheath in a way that we don't fully understand yet. Otherwise, we would be able to cure MS, and it's not currently curable. We just manage it. So the lymphocytes move from the bloodstream through the blood-brain barrier into the central nervous system and damage the myelin. So Joanna's given you a feel for how common it is. Nobody really knows for sure because it's not a reportable condition in the way some are, but it's estimated 2.5 people in the world have MS, and it is about 140,000 in the UK. As she said, 100 a week. It does feel sometimes like all of those are at Charing Cross, but they're not. They're spread all around the country. This is quite a good summary slide of sort of some of the things that we've talked about. So we know that the prevalence is higher in Northern Europe, and there's quite an interesting theory why. Well, it's not just a theory. There's quite an interesting explanation for the geographical spread, actually, which I'll come to in a second. But it is more prevalent in women than in men. But in fact, men tend to have a worse prognosis when they are diagnosed. It's predominantly diagnosed between the ages of 20 and 40. So it's a young person's disease. It often presents in young life. And if you think that 20 to 40 are mostly women, it's women of childbearing age that we are quite often treating, which is something you have to think about when you're giving them drugs, obviously. There is an increased risk amongst first-degree relatives. So that doesn't mean that it's inherited. It just means there's a genetic predisposition for you to get MS if you have a family member who has it. Now, this difference in latitude, if I was doing this live, I would ask for suggestions why you think this might be, because what it is actually connected to the distance from the equator. So if you think about the further away you are from the equator, the higher the prevalence of MS. And that's broadly speaking because of sunlight exposure and vitamin D. So basically countries that have high sunlight exposure and therefore probably better vitamin D have a lower prevalence. And that's true also in England, where the highest prevalence of MS is in Glasgow, where the sun never shines, and the lowest prevalence is on the south coast. And similarly across Australia, it's more common in the south than the north. So we don't know what causes it. It's multifactorial. There is certainly some genetic predisposition. Vitamin D may be involved. There's a strong argument that all of this might be triggered by a viral infection in childhood. And there's one school of thought that it's the EBV, Epstein-Barr virus, that might trigger MS. And smoking makes everything worse. And certainly it doesn't help with MS either. So as was in the poll, the diagnosis, you can't do a definitive test for MS. You essentially have to rule out everything else and have a neurological exam to start with. And then you have a series of tests involving an MRI, a lumbar puncture to check proteins in your cerebral spinal fluid. And they also do something called the visual evoked potential, which is where they measure the speed of nerve transmission in the optic nerve using flashing images and electrodes to work out if that's working properly. And then there's a set of criteria called the McDonald criteria, which we won't go into today, but that you have to fit those criteria to get a diagnosis. So clinical presentation is incredibly variable. So as we said, it's anywhere in the central nervous system can be affected, and therefore any part of the body can be affected. So this is a slide I borrowed, I think it was from the MS Trust or Society, which sort of summarizes it quite nicely. You can see all the different ways that MS can affect somebody. And the colours just indicate how those are the things that are more common on first presentation. So the red ones are how people often first present, with episodes of numbness or tingling. Maybe they feel like they've got pins and needles in their hand or their foot. Vision problems are very common. So optic neuritis is often the first presentation of MS, and that's blurring of vision or loss of vision or pain on moving of the eyes. That's often treated by ophthalmologists with steroids. But anyone presented to an ophthalmologist with optic neuritis should really then get a referral to a neurologist to check out whether they've got anything else going on. And then all of those other things which are not commonly known for people that have MS, bladder and bowel dysfunction, muscle spasms and muscle weakness, pain, and very commonly depression and cognitive dysfunction, which is the memory loss that Joanna was talking about with her grandma. That's very common. And fatigue is a really big problem for people with MS. It's not just being tired, it's a completely different thing. It's being completely wiped out and not being able to do quite normal functions sometimes. So there are 4 types. This is probably needs updating, this slide, because people's thinking is changing about how we define MS. So in the past, these different subgroups of MS have been described, and people are still sort of diagnosed and pigeonholed into these different groups. But actually the school of thought now is really MS is just one disease, and people are at different parts of a pathway in that disease. And so we're talking about people having relapsing or progressive disease with or without activity is how people are describing it now. But the bottom one of those 4 there is relapsing remitting MS. That is the most common form. So what happens if you look at, I don't know if you can see my cursor there, but so this is increasing disability up this axis and with time across the bottom. So what you have is an episode or a relapse where you get a temporary increase in your disability, and then hopefully that remits or goes away and you go back to how you were before. So for instance, as I described, the numbness or tingling in someone's hand, that might last a few days and then go away and they're back to their normal function. Or the optic neuritis and the blurring of vision would last a few days and then disappear, and hopefully their vision will be completely restored. Sometimes it doesn't completely go away and they're left with some disability as a result, maybe a slight loss of vision or a weaker leg. And then over time, with each attack and relapse that they get, the disability may get worse. So that is the most common form, and it's the only form for which we really have any drug therapy. Having said that, just last year we got drugs for primary progressive MS, and this is much less people get diagnosed with this, but this is unfortunately a form of the disease where you don't have these episodes that go away and come back. You just get an accumulation of disability over time. Secondary progressive MS, the third one up here, often people with relapsing remitting disease will eventually go on. So they'll have this period at the beginning where they've got relapses, and then eventually, usually after sort of 15, 20 years or so, they'll move into the progressive phase where they'll just get worse without any relapses. So drug treatment, as pharmacists, we're all about the drugs. So what do we give people with MS? So in order to treat all of those individual symptoms that we've talked about, we treat them in the same way that you would if you had any of those problems but didn't have MS. So you get the symptomatic treatments that Joanna talked about with baclofen, diazepam, that's for muscle spasms. You treat pain, neuropathic pain, in the same way that you do with things like carbamazepine, amitriptyline, gabapentin, pregabalin. Spasticity, I've just mentioned, tremor, depression is treated in the normal way. Fatigue, there are no drug treatments that are effective for treating MS fatigue. It's an area of research that we've not managed to come up with any treatments for that. You might see occasionally people on amantadine or modafinil, but they're unlicensed and usually hospital prescribed. Sexual dysfunction is common, as are bladder and bowel dysfunction, and often those things, bladder and bowel dysfunction, result in infection. So UTIs are very common for people with MS. If they do have a relapse of their disease, we treat them with high-dose steroids. So we use methylprednisolone, it's a more potent form of steroid. We usually treat it orally with a 5-day course, and that is the correct dose. So people often, when they first see a dose of methylpred for MS relapse, sometimes query it, but it isn't a BNF, it's the right dose. It's 500 milligrams a day for 5 days. If they have a significant relapse that requires hospitalization, we give it to them IV just over 3 days. Now, steroids for a relapse do not reverse the disability that you're going to get with your relapse. They only speed up the relapse. So they're not actually curative or modifying the treatment the disease in any way. They're just speeding up the recovery from that relapse. So if someone goes off their legs because they get sudden leg weakness, it might speed up the reversal of that, but it won't change the inevitable outcome. So what we're trying to do and in hospital, in where I work, and my day-to-day job is in managing disease-modifying therapies for people with MS. And that's trying to slow down the progression of the disease. So the treatment aims for disease-modifying therapies are to reduce those circulating lymphocytes. If you remember, I showed you a slide where the lymphocytes go from the blood into the CNS and attack that myelin sheath. So all the drugs for MS are aimed at stopping that process, and they do that in a variety of different ways. Now, we haven't got time today to go through all the individual disease-modifying therapies, so I'm just going to give you a little whistle-top tour of what they do. So the point is that then you're going to reduce that inflammation being caused by the immune system, and therefore hopefully reduce the relapses, the number of relapses that people have, and therefore the damage that's being done to their central nervous system. You measure that not only by clinical examination, but by giving them an MRI scan, and you can see MS lesions on an MRI scan as little white dots on the brain and spinal cord, and you're aiming to reduce the development of those. You can't reverse them once they're there, but you can prevent new ones occurring. And the whole point of all of that is to slow down disability progression. So when I first started in neurology, treatment options were very limited. It was before 2010. But in 2010, we had two options. If you had relapsing remitting MS, you could be offered interferons or Glatiramer. If you had what we call highly active or rapidly evolving severe MS, you could have a monoclonal antibody called natalizumab. And that was it. Prior to that, so for about 20 years now, we've had the interferons. Prior to that, there was no treatment, and people were essentially told to go away and expect to end up in a wheelchair. That's really not the case anymore. We can offer people an awful lot of treatment, and that's the reason I have a job, is that we have a lot of drugs now that require the help of pharmacists, and that's why neurology and neuropharmacy is a growing career for people coming into pharmacy. There weren't really many posts at all when I qualified. So now, as you can see, we've got, depending on how you count them, because some of them there's more than one type of those drugs, it's about 13 therapies now for MS. Not everybody is eligible for all of them, and we won't go through that today, but there is a much more choice for patients than there used to be. But that level of choice can actually be confusing for people, clinicians and patients alike. It's a bit overwhelming. You don't always know which one to pick. So NHS England, who pay for all of these drugs, they use particular criteria that we have to meet in order to pick which one people are eligible for. Now, again, if I was in the room with you, I'd be doing a little quiz now and getting you to guess how much the NHS spends on disease-modifying therapies. But I'll save you that and just tell you it's an awful lot. So we'll think of a number in your heads, and I bet none of you came up with that figure. So it's £300 million a year in England alone. Okay, so that's just England, not Scotland, Wales, and Ireland. It's a hugely expensive disease. So Joanna mentioned the cost of somebody with MS. I don't know if that was the drug costs or just the costs associated with them having a disability, but the average drug costs are about £12,000 per patient per year. And then the additional costs of them being looked after and whatever additional help they need on top of that. So there's a big social care bill that goes with MS for people that need extra help. And the whole point of some of these treatments is to keep people in work and keep them active, because as I said, it can first diagnose quite young in life. So by putting them on treatment, you're trying to keep them active and well for as long as possible. I lost my cursor, there it is. So how do we choose the drugs? Well, as I said, NHS England have got commissioning policies that help us choose between the treatments, and all of them have been nicely praised and have good evidence for that. But lots of different factors will affect what treatment people choose, or if they choose a treatment, and a lot of people are not on treatment. But the treatment choice will be affected by things like things they've already tried, what the clinician's experience or preferences might be, what the risks of those treatments are. And there's a lot of patient factors that come into play there about what risks people are prepared to put up with. Obviously, there are some direct contraindications to certain treatments. Family planning is a really big issue for us because most of our patients are young women of childbearing age, so we have to think about how pregnancies might be affected. And then just simple lifestyle choice. Some people prefer to take a tablet every day. Some people would prefer to have an infusion every 6 months. there's different reasons why people choose different things. And sadly, service capacity does have a bearing, because we might be able to get you onto one drug quicker than another, depending on waiting lists and things for infusions. So I'm going to run through a little bit about how these drugs work and what their modes of actions are. Not in a huge amount of detail, but just to give you an idea of how they work, and therefore I'm going to talk a bit about the risks. Now, I don't expect you to read all the detail in this slide, so don't panic. It's just to illustrate a point. There are 3 phases. I've talked already about lymphocytes coming out of the blood and going into the central nervous system, which is what's happening here at the top of this diagram. And that causes so that the immune cells come in, they attack the nerves and cause demyelination. And eventually that causes axonal damage and nerve death. And that's what causes the permanent disability that people get with MS. So these 3 phases of damage, the drug therapies are all focused in the blue circle in the inflammatory phase of the disease. We don't have any drugs that repair myelin or regrow myelin, and nothing can repair or reverse nerve death once it's happened yet. So I'm hoping that by the time you all qualify and become the neurology pharmacists of the future, we might have some drugs that do regrow myelin, which would be amazing. And we might have developed some more exciting stem cell therapy that might regrow nerves. And those are very real possibilities. So I'm hopeful for the future for people with MS. But at the moment, all the drug therapies are in the inflammatory phase, just trying to prevent this stuff from happening. So the general principles are that we suppress the immune system, or we modulate it in some way to stop those lymphocytes getting to those nerve cells. And you do that by either depleting the circulating lymphocytes from the blood, or stopping them from proliferating or duplicating, or you trap them in different parts of the body, or you modify the way they move about. Now, I looked everywhere on the internet for a picture that told you what I wanted it to say, and I couldn't find one, so I drew one. So excuse my very poor artwork, but this is a person with MS. And this is just to illustrate what's going on. So you've got B lymphocytes coming out of the bone marrow here. That's the red cells. You've got T lymphocytes being released from the lymph nodes here into the circulation. And that's why they're called T and B cells, because they come from bone marrow and the thymus gland. So the green T cells and the red B cells interact in an abnormal way, and they cross the blood-brain barrier, and they cause this yellow star, which is an MS lesion in the brain, which then gives the patient the symptoms. So the treatments are aimed at stopping that process, and they do that at a variety of stages depending on the drug. So I'll come back to that diagram in a minute. So the oldest drugs I mentioned that we have are interferons and Glatiramer. So their mode of action is very broad, sort of anti-inflammatory action. They don't have a specific site of action. They reduce circulating inflammatory proteins. They're self-injected by the patient. They're usually delivered via home care. And we talk about the effectiveness of drugs in MS by the percentage in which relapses are reduced. And they're thought to be moderately effective by causing about a 30% reduction in the number of relapses that people have. They have really very few side effects. They're quite safe drugs, other than injection site reactions, which people get, and flu-like reaction after they've injected. People might feel a bit fluey. So they have paracetamol often as a pre-med. That's just an example of some of the different brands that there are. And you can see that they're injected either intramuscularly or subcutaneously 1, 2, 3 times a week. The one that's every 2 weeks is a pegylated version, so a longer acting version, so it's only every fortnight. But you do get a bit more side effects with that one. Then, quite excitingly, only about 8 years ago now, we started getting oral treatments for MS. And that gave us a lot more treatment options. So the first one was actually the fingolimod, but then since then, quite in quick succession, we had dimethyl fumarate or tecfidera and teriflunomide. They're given as tablets either as first line or second line in the case of fingolimod and cladribine. And the tablets are either taken once a day, or tecfidera or dimethyl fumarate is twice a day. Cladribine is actually given as a short course once a year, so it's more of a chemotherapy type agent. So you give it for 5 days in year 1 and then again in year 2. But they're all considered to be more effective in that they reduce relapse rates by upwards of 50%. I won't go into all their details, but they do have a range of significant side effects, and pharmacists are very involved in trying to manage those side effects and advise people how to manage those side effects. So, for example, tecfidera or dimethyl fumarate has a lot of gastrointestinal upset. When people first start taking it, they often feel quite acid reflux, diarrhea, tummy upset, those kind of things. So there's a lot of over-the-counter stuff we can help advise people to buy when they start that drug. Equally, they also quite often get flushing of their skin, like a hot flush of their skin. Those things do go away after the first few weeks. Teriflunomide can cause some reversible hair thinning, which obviously a lot of people don't like the sound of, and diarrhea, which is equally unpleasant. And they all require regular blood tests. So that's a big part of what pharmacists do in MS, is helping to safely monitor the drugs. And because they're all immunosuppressive in some way, infection is obviously a big risk. I actually haven't got a slide on COVID-19. This is the first presentation I've given for ages where I haven't mentioned COVID-19, but I just did. But so infection is a common side effect, and COVID-19 is an infection, so it does put them at more risk. But it's probably just important to say now that none of these drugs require shielding. When COVID-19 first happened, we didn't know what the effects were going to be. But we've learned since that that the infection rate in people with MS is not greater because of drugs. It might be increased in people that are more disabled for other reasons, but the drugs themselves do not significantly increase your risk, and therefore you don't need to shield. But they do cause lymphopenia, so we monitor the blood regularly, and you get quite a significant drop in your lymphocyte count. And GPs may often look at the blood results and panic, but we're quite thick-skinned when it comes to low lymphocyte counts in the MS team. And you get to, like I said, they have to have regular blood tests for those. And then you have the infused therapies that have come on over the years. So we've had natalizumab for quite a long time, since 2007, but more recently we've had two newer drugs, and just 2 years ago now, ocrelizumab joined the party, and that's probably the most commonly prescribed drug at our centre now. So these are all monoclonal antibodies, and they're acting in different ways. Natalizumab has a very specific mechanism of action in it. There's an adhesion molecule on lymphocytes that makes them stick to the blood-brain barrier, so that they then move in. It blocks that adhesion molecule, so they just roll along past the blood-brain barrier and don't go through. Alemtuzumab just destroys, it latches on and latches onto a surface receptor and destroys the B and T cells. And ocrelizumab does the same, but specifically for B cells and not T cells. So they all have infection as a significant risk. Alemtuzumab also has some autoimmune side effects, which can be quite significant. So there's a very rare chance of having irreversible renal damage. Very common to have thyroid abnormalities with the drug. PML stands for progressive multifocal leukoencephalopathy, which is a bit of a mouthful, which is why we call it PML. And that's a fatal brain infection, which is a risk with some of the treatments, more so with some than others. Natalizumab is the one that's the worst culprit for that. And we have to counsel patients about that risk. And all immunosuppressive therapy is in some way linked to a possible increased risk of cancer. So nobody fully understands yet what those risks are. But certainly some of the drugs that have been around for longer, like fingolimod, have a known increased risk in certain types of cancer. So we obviously have to counsel our patients on that potential risk. And that's because your immune system, as well as scanning the body for signs of infection, has a big role in scanning for early cancer as well, and destroying early cancer, signs of cancer. So we think that's probably where it is. So back to my stick man or woman, not sure which. So this is just to illustrate the different drugs I've mentioned are in pink here. And you can see they're acting in all different parts of the body. So as I said, natalizumab acts specifically to stop those cells getting across the blood-brain barrier. Teriflunomide and dimethyl fumarate reduce the circulating lymphocytes in general. Ocrelizumab specifically gets rid of those B cells. Cladribine and alemtuzumab specifically take away B and T cells. Interferons have a sort of general effect on the immune system to reduce the inflammatory proteins. It's worth mentioning bone marrow because I haven't talked about that, but all of these cells faulty immune cells come from the bone marrow. So having a bone marrow transplant is now actually a very real treatment option for people with MS, and we do give bone marrow transplants to some of our patients. You have to be specific type of patient to get a bone marrow transplant. We can't offer it to everybody, but it is quite a successful treatment in some people to just reset their faulty immune system completely. So this is quite a busy slide, and I don't expect you to read all the detail, but it's just to illustrate what the different treatment approaches might be. So as I mentioned, in the bad old days, when we didn't have very many drugs for MS, you'd get this thing called watchful waiting, which is basically people just told to go away and wait till they got worse and then come back and see us. Unfortunately, we don't do that anymore. And then consultants in the sort of even 10 years ago, and some still today, some people might say, are very slow to put people on treatment and would offer them the safest treatments in terms of risk, and those are those early interferons, and then wait for them to get worse and then offer them something else, and then wait for them to get worse and then offer them something else again. And they used to, and this is probably where we are now, the middle triangle, where we don't watch and wait. We offer people a range of treatments, and then we move them up to the more effective treatments quite quickly. Now, there is a school of thought that we should what's called flip this pyramid completely and just hit people hard at the beginning with some of the much more effective treatments. And the jury's out amongst the MS clinicians about what the right thing to do is. So there's clinical trials going on that are comparing these two treatment strategies to see which one actually has the best outcomes. But if people are prepared to take some of the risks of the more highly effective therapy, there is a strong argument for giving them early and trying to knock the disease on the head completely. So the important bit, the role of the pharmacist in all that. So historically, there weren't a lot of pharmacists in MS because there weren't a lot of drugs to offer people, and so they didn't need us. That's different now, and that's why there are a hugely growing number of neurology pharmacists. So when I joined, I put this slide up because it made me laugh. I was asked to do a presentation to non-pharmacists on the role of pharmacists a couple of months ago, and I Googled an image looking for pharmacists, and this is what you get if you Google pharmacists. So apparently we all stand in white coats in front of shelves of tablets. At least we're all smiling, but I mean, it's really not a typical image of the pharmacists I know anyway. When I started, and it was 26 years ago, I qualified as a pharmacist, there were very few super specialist pharmacists, and these specialities actually, when I put this together, I realized followed my career a little bit. When I went traveling in the 90s to Australia, I worked in an HIV clinic. But when I did my pre-reg at Chelsea and Westminster, we had 2 inpatient wards looking after people with HIV, because if you got a diagnosis of HIV, you were generally unwell and admitted to hospital. And then when I went traveling to Australia, I did some locum work in an outpatient clinic where we dispensed treatments for HIV. And so with the advent of all these new treatments for HIV, there came the need for specialist pharmacists. So HIV specialist pharmacists have been around for quite a long time for that reason. Then when I came back to the UK, I was a dispensary manager for a bit. And that was the time when all of the new drugs for chemotherapy, oral chemotherapy, were coming to market. And there was a really, really increased need for pharmacy involvement in managing oral chemotherapy. And then a little while after that, all the new rheumatology drugs came out. And so we've got specialist pharmacists in all of these areas. And neurology is just a bit late to the party, really, because we've only really got our drugs in the last 10 years or so. And that's been recognised by quite a lot of people. So the MS Trust, which is a charity that supports patients and staff working in MS, have brought out documents that say that MS teams should all include a pharmacist. NHS England then followed suit and produced a document around MS that also said MS teams should ideally include a neuropharmacist. And then more recently, there's something called NHS Right Care that produced toolkits for looking after people with progressive neurological disease. And in the section on MS, they say a key area for focus is the increased use of pharmacists. So I'm very pleased to say that all of these things mean that you will all have a lot more career options in neurology than were available when I first qualified. And we're developing training academies and syllabuses with the UKCPA and the RPS and the Neurology Academy to offer training courses for people, because at an undergraduate level, you don't really get any training on these kind of things at the moment. I think it's very much sort of stroke and Parkinson's And that's about it when it comes to neurology. So what does the MS pharmacist do? Well, we're very much part of the multidisciplinary team. We meet weekly. We have a multidisciplinary team meeting once a week, and there's the pharmacist there is always called on for advice in some way or other to advise on what drugs people might be eligible for, what the NHS England rules are, how they can switch people. The pharmacist in most teams in all specialities is really the lead on governance. We're quite well trained in how to keep people safe. That's what we do. So we lead on governance within the team. We have a big role, obviously, in patient counselling and talking to them about the side effects and the mechanisms of actions of their drugs and what to expect. I have a lot of conversations with patients about the risks and benefits of treatment. It's quite a big decision to make to go onto some of these treatments. So you have to explain the risks of the treatment, but also the risks of not taking the treatment, which people sometimes forget to put into context. And I take consent from people for their infused therapy. We do a lot of writing of guidelines and policy, a lot of education and training, and I'm very involved in audit and research within the team to try and not only show what we're achieving with the drugs, but also it's really important to demonstrate the value of the pharmacist in the team and what we're bringing. I am a non-medical prescriber, and I think I understand now that that's part of the undergraduate course, and so people coming into pharmacy will already be prescribers, which I'm not sure how I feel about. I have to be perfectly honest. I think there's different arguments for that, but it's great that we do need prescribers in the profession. But there's a lot of work to be done on making sure people are competent to do that, and so non-medical prescribing is key for neurology pharmacists. We do a lot of screening and monitoring of therapy, and I actually have a clinic. A number of us now working in neurology have clinics where we see patients in pharmacy-led clinics to manage their disease and their drug therapy. So we have a network which anyone can join. So feel free if you have an interest. The UKCPA Neurosciences network. You can join up, and there's an email online forum where people ask questions of each other. It's a really useful support network if for people working in neurology. We have an email group. We have when we were allowed to meet face to face, we used to have national meetings. We're looking obviously to move those online at the moment, and it's a good place to sort of share best practice and problem solve. And as I said, we're trying to develop training programs for junior pharmacists in neurology so that they've got a syllabus to follow. And the group has also had a role in policy development nationally, and we're involved with stakeholders in NICE consultations and things like that. So that's me, whistle-stop tour of being an MS pharmacist and all about the drugs. So if there are any questions, feel free to shout them out in the chat.
That was brilliant. That was really good. Loads learned there, definitely. Definitely going into the CPDs.
Yeah.
That is up and coming. I've just had a wee nosy. Your group there, guys, you can join free as a BPSA member. So if you know your membership number or find it out, you can join for free.
I'm just trying to work out how I stop sharing.
At the top.
Oh, there it is. Yeah, got it. There you go. So there's a couple of questions. How much does funding affect choice of drugs? It doesn't, because the drugs are all funded by NHS England as long as you're eligible, as long as you fit the criteria. So patients have to fit the criteria in order to get treatment. For most of those, the criteria is just that you have MS, or that you have MS and you've had a relapse within the last 12 or 24 months, or you've got a change on your MRI scan. So whatever's happening, you are eligible for a drug. And then the drugs that you're eligible for, you're offered all of them regardless of the cost, because all the costs are reimbursed by NHS England.
There was a question earlier about the relapses, how long that kind of timeline is they were asking.
How long a relapse will last?
Or kind of like the timeline of the relapse in MS, they were saying how kind of is that timeline if you're going through the different relapses, if you're gradually getting worse?
So I see. So a relapse itself is defined as having symptoms that last more than 24, 48 hours and then remit. How many relapses you have over time will very much depend on your disease and how active it is. And lots of people are very different. So some people may have quite what's sometimes termed benign MS, where they don't have relapses very often, and therefore they don't get very disabled very quickly, and they can live quite normal lives for quite a long time. Other people, unfortunately, have much more aggressive MS, where they have a lot of relapses in a short succession of time, and therefore their disability progresses. But I suppose on average, I think people probably have a relapse every 2 years or so, if they're lucky. And it takes 15 or 20 years and longer if you're on good therapy for you to become more progressive and more disabled.
Brilliant. Any more questions? No? Oh.
Someone's asking if they can access my slides. I'm very happy to email them to you, Joanna. You can share them with people. That's fine.
I'll send the slides out to everyone after the event, and the recording will go up on the BPSA YouTube as well. So if you're wanting to listen to anything back, it will all be online.
Great.
All right. Perfect. Well, thank you very much. That was brilliant. So now I'm going to introduce Amy. She is a representative from the MS Society. Hi, Amy.
Hi there. Can you everybody hear me okay?
I can hear you perfectly fine.
That's okay then, because I'm not very good with technology.
No, it's taken
right. Well, it's been it has been really lovely hearing about the clinical side of MS, and I'm here now to tell you about the personal side of MS. And as Joanne said, and also, sorry, I've forgotten everybody's name. It affects every single nerve in your body. If there's a nerve it can affect, it will, and whether you like it or not. Living with MS is bloody awful at the best. And as has been said, it's mostly women in childbearing age. I was 34 and I had 2 young children when I was diagnosed. I'm now 43, and it has been a very long journey trying to find the right drugs. I had quite a hard episode at the beginning. Hard relapse. When I was first diagnosed, I ended up in hospital for 3 or 4 weeks, and again the tests, which are horrible, the lumbar punctures, and MRI, blood tests, but it's what needs to be done to be diagnosed. However, you lovely people, the pharmacists, you're our angels, because you're the ones that help us manage our lives. Drugs are incredibly important, not just for helping prolong episodes in between, but also for managing day-to-day life. I don't know how much you do about CBD oil and cannabis.
We haven't learned, I know personally I haven't heard a lot about it, but I've heard a lot kind of with my gran and stuff about it. It's a great area. Great.
Well, it shouldn't be, because it's marvelous. I got prescribed the spray, Sativex spray, several years ago, before they banned it and then reintroduced it. So I have that now on repeat prescription, and I have gone from, I was walking and losing one leg, the use of one leg, so the other leg would keep going and the other leg would just go dead. So I was face planting on a regular basis, very unladylike. And I went to my GP and I'd researched Sativex, and he said, right, okay, I'm fine, let you try it, because he knew that if I didn't think it worked, I would just say it doesn't work. But for the spasms, absolutely, it's like chalk and cheese, being able to use something that is ultimately organic, because it's comes from greenery. And my mum always told me to eat my greens, so I'm taking her advice. But it is really, it's been really good. Now, I'm the branch coordinator for Fife MS, and in Fife alone, we've got over 900 people with it. And when people talk about episodes and relapses, lots of us do not go to the doctor when we have a relapse, because the only option is steroids. And we know that, and we know it doesn't actually cure the relapse, or it doesn't speed it up. So the damage is still done. But we're also aware that steroids can cause osteoporosis in later life. And people who are prone to falling really need as strong bones as they possibly can have. I'm trying to think. It's mentioned about that on paper. You read it. MS causes this. It causes that. It causes sexual dysfunction. It causes bladder weakness. Bladder issues, bowel issues. But living with them is another whole kettle of fish. And it's like the old saying, you don't know what it's like until you actually experience it yourself. And you can watch someone have it, and you don't really understand what it is. I mean, you can see the pain, oh my God, the pain is unbearable. With nerve atrophy, I can only describe it as barbed wire being pulled through your veins backwards. It is agony, absolutely. And nobody can touch you, because if they touch you, it feels like they're stabbing you with blades. It is awful, awful, awful. But CBD has helped with that. The drugs that we do get to manage pain, to manage discomfort, they in themselves, they cause so many different issues. Gabapentin is, I was prescribed a really high dose for nerve atrophy, and it wasn't any quality of life. I was literally lying on my sofa, zombied, because I was on, I think, 600 3 times a day.
I took gabapentin for a while, and it totally wipes you out. You feel like you could wake up at a normal time in the morning, and as soon as you take it, you feel like you could sleep a whole night's sleep.
Yes. And that it is, and it is. I mean, and from a medical perspective, people, yes, it does get rid of the pain, but I don't know whether it gets rid of the pain or whether you're just too stoned to actually care about the pain. That's what I'm trying to figure out. And, I've talked to people who are also on gabapentin, and they went, actually, yeah, because you're still in pain, but you're too munged. Excuse the terminology. You're too actually munged to vocalize that you're in pain. So from the onset, people coming in, you don't look like you're in pain. But then again, you're not really in a human state at all. And I really find that's difficult, trying to find medication that actually does the job, but leaves you in a state that you can actually live your life fully. Do you want to know symptoms from a first-hand experience, or?
Yeah, definitely.
Right. Pain, that can affect every part of the body. Now, one that always, and I give talks to the medical students, and the one thing that I ask them is, I tell them, is that because it affects every part of the body, and people do not speak about it, but it does affect your nether regions. So you can feel that it gives the impression that you are turned on, right? But trust me, after 5 hours of having that, it becomes very unpleasant. Well, it becomes unpleasant long before the 5 hours. But people don't talk to the doctors about it because they're embarrassed. With men, they can have erectile dysfunction. I give talks to care providers, because there was one man who constantly had an erection, and it wasn't because he was turned on by the carers, but carers were young and they thought he was being a pervert. He wasn't being a pervert. It's just what happened, so that's one of the instances. Spasms, they can be quite comical. The inability to form your words. I'm doing quite well today, but there are times when you don't make any sense whatsoever. The words are there. You can see them in there, but they are not coming here. And that's a problem that you have. And the words that do come out, they don't exist in the English language. And at the MS groups, there's been a lot of talk about that, because I think for people who are dealing with people with MS, encourage them to go to a support group, because what we don't do is we don't sit there and cry. We don't sit there and moan. What we do is we say, oh my God, has anybody had this? You know, and there's a lot of humor. We deal with it with humor, a lot of humor. And people coming into that environment are sometimes shocked at what they're hearing. But that is one way of dealing with something that is basically awful. Trying to get your family to understand, you know, on one hand, you do not want them seeing you in that level of pain. I don't want my children having to pick me up off the floor. But now they're teenagers. They've seen me in states falling down in parks, and that's without a drink, I might add. So it's trying to, I think what I would say to pharmacists is, don't dismiss CBD. Do not dismiss alternative therapy. Massage, fantastic at trying to ease some of the symptoms. I would always advise people with MS to maybe look at different things. Look at, is your body lacking vitamins? You know, because quite often they are, because eating is another problem. Sometimes you can't swallow. I don't know if you, but the liquid and food, it gets stuck. So you tend not to eat anything that involves a lot of chewing. And the one that we all quite suffer a lot with is trigeminal neuralgia. Again, the pain, and that triggered by eating, and it can be triggered by all sorts, but that is very, very, very painful. And you go to the GP, and what they say is drugs, 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 because that's the only way they know how. That's what their job is, really, isn't it? And I've had the best advice from pharmacists who have said, have you tried this? Have you tried that? Or I had someone come in who had MS who told me they had tried CBD balm for spasms, for pain. And you think, oh, okay, I'll give it a go, because you will give anything a go. Because if you actually, my medicine cabinet has, it has a street value. It really does. I could be really rich if I wanted to be. If I didn't need them so much, I'd be mega rich. Because, you know, we're on, I've gabapentin, I've got my Sativex spray, I'm on Tecfidera, which is a disease-modifying drug. And I would just like to say, I would just disagree. The flushing does not go away necessarily within a few days. I've been on it a few years and I still get horrendous flushes at times. What I would advise is you take it with high-fat food. You know, I used to be a size 8, you know, before Tecfidera. I'm lying. But if you take it with something fatty, it does help reduce the flushing. If you take it with an aspirin, it helps reduce the flushing. So there you go, a little handy tip. So I don't know, what else would you like me to say about MS?
It's just really interesting to get a personal kind of perspective. Have you had any kind of issues with memory or anything like that?
Oh God, yes. I don't remember anything. I had to get a reminder from the MS Society that I was doing this today, because I would have forgotten. So they set up an email to remind me yesterday and also to remind me today. The amount of times I've forgotten, and it's not just old age, it's memory. Is your brain feels like it's just been made up of soggy cotton wool. There's nothing, you know, there's something you should be remembering. You just can't remember what. And also that, yeah. So memory It's terrible. And fatigue. Now, the fatigue, if MD knows a cure for fatigue, you'll be rich. It's horrible. And it's like someone said, it's not tiredness. It's like someone has cut your legs open and filled them with cement, and your arms and your brain and your entire body, and you physically, it's not tired. This is different. It's not tiredness in the least. A nap does not help. Red Bull does not help. And it's like you physically cannot move your body. You physically cannot move. It is so, it's like not only are you filled with concrete, you've then got to try and walk through treacle to get to where you're going. And that in itself, that is exhausting as well. So you do have exhaustion on top of the fatigue. I saw a question about what age. I think the most common age is between 20 and 40, from my understanding. That's the most common age. But you know, I do know someone whose child was diagnosed age 7. And although, you know, about the drugs, when we're talking through the drugs, I don't think at any point were we told, and none of my group, none of Fife that I'm aware of, were told about the cancer risks, because we have actually specifically asked our neurologists, is there a risk to increased cancer? And no, not at all. And that's a lie, as I found out. Bit of a shocker. But it would be good to know that. I think that they've got to, if doctors stop treating us like stupid people, like idiots, like we, because they're quite dismissive.
Would have been as much research as you could have possibly done. So it would have been anything, you would know enough, because you would have looked up everything. Yeah. You'd want to know everything you could. Yeah.
You do. That's the first thing you do, is go to Dr. Google, which isn't all necessarily a good thing. But I think if neurologists, and I don't know whether it's just because they're super intelligent people, that they think that we're all below them, so below them that we don't deserve to be told the truth, to be told honestly what everything is. I mean, I went and you know, I was given a list of treatments that I could do. Obviously, I researched them, and I asked specifically about cancer because I had read about it. Now we've got cancer that runs through the family, and he just went, oh, don't be silly. It doesn't. None of the drugs cause cancer. But don't look it up on internet, because I'd said, well, I've researched it, and that's what it said. But I think as health professions, you have to be honest with us. You know, you can soften the blow a little bit, but you know, be honest with us, because we need to be able to make these choices ourselves and be able to say, right, okay, that's what we need to do. That's what we need to take. That's what. And the other thing I would suggest, which is what I say to the GPs rather than pharmacy, which I don't know whether it would work the same. Don't assume everything is MS.
No.
You know, don't assume if you go in that it's MS. Yeah. Because we get that a lot from GPs is, oh, it's MS. Oh, it's MS. It's MS. And you know, it's not. You know, some things are not MS.
Yeah.
Yeah, we can be ill. Just because we've got MS doesn't mean we can't be ill. And that's what I would say.
No, that is brilliant. I think it's really important for us to hear a personal kind of perspective and see how we fit into that. Because obviously it is important that we do know, even if it's something like taking aspirin with, like, to stop getting the flushes, and it's things like this that it seems something that we might not know, but if it helps someone, it might help someone else. It's being personalised and helping people any way we can. Rachel's actually just going to talk briefly about the benefits of CBD just after you mentioned that, and just talking about it. Yeah.
I tell you, the benefits are absolutely, I mean, I can't over. My daughter just came in with a broken bra. Sorry. Right, Christy, go away. Right. I don't know what she wants to do. She expects me to sew it. I can't sew. Right. The CBD is it's a game changer. It really is a game changer. The pain it helps with pain. It helps with spasms. The CBD balm as well. That's a topical if people aren't so keen on taking it. And I know many people in Fife alone that actually will take the raw material because they cannot get the prescription, because it's not easy. You can't. It's you know, it was legalized, but however, you can't get it. I think one person I know of in Fife managed to get the prescription. Wow. To help, because people are so, and the thing is, it reduces. I have now, from taking all those gabapentin, I only take 2 at night now.
Yes.
Oh, what was that? Was that me? Yeah, so I've reduced taking prescription medication right down. And the good thing with the CBD oil is I can just take it as and when I need it. I don't need to take it in preparation. Like, you have to take gabapentin in case something happens.
Yeah, I think Rachel just disconnected, but she's back in a second.
All right. So that's what I would say is that, and the argument that we've been told it's because of cost, but in actual fact, if you're removing the other medication from the prescription because you're not needing it, then it's probably more cost effective.
Yeah,
maybe. I don't know how much these things cost, but and also it doesn't make you off your face, because you know the THC and the CBD oil are level, and it's got to be level. And unfortunately, the people that are taking the raw material, the THC level, is higher than the spray would be. Therefore, they are getting stoned, which then puts them at risk of falling and all the rest of it. However, it does get rid of their spasms. It does get rid of their pain.
Yes. Yeah. It is definitely something for us to learn about. There is a lot of benefits. How did you kind of go about getting it? Was it just from the GP, or?
I just got it from a GP, and it must have been about 6 years ago.
Really?
And I had a really good GP. And I went in and I said, look.
Which is really unusual. Joanna, can you hear me?
I can hear you now. Yeah, I think you disconnected. Oh.
Yeah, so it was really unusual to have sorry. Do you want to talk, Joanne?
No, it's okay. I was just letting Rachel know I could hear her now. She disconnected.
Sorry, yeah, I've had to move because my Wi-Fi was kept dropping out. Sorry about that. I'm now standing at the top of my stairs to talk to you about cannabis. So just to say that just for the pharmacy students to understand a little bit about the background, because it's quite complicated, the medicinal cannabis arguments, and just to put it into some context. So obviously medicinal cannabis became prescribable on the NHS in November 2018, but as Amy's described, it's really difficult for people to get hold of it. And the reason for that is there's only one licensed preparation available to treat MS spasticity, and that is the Sativex that Amy's talking about. And that's a 50-50 combination of THC and CBD. So tetrahydrocannabinoid and cannabidiol are the two components of cannabis. And it's a 50-50 combination of the two that's prescribable. And the CBD products that you can buy over the counter only have the cannabidiol proportion, because if they have more than 0.2% of THC, then that's illegal to be sold. But the difficulty is that those products are not regulated, and they can, in fact, not have very much CBD in them at all. And the benefits really are at much higher concentrations. They do wonders for people, as Amy's described. You know, people find them really beneficial, but you have to be really careful about what you're advising people to take, because some of them have very little in them at all, and so that's the difficulty. And in Scotland, it's slightly different. That you're able to get Sativex from your GP is fantastic. You wouldn't be able to do that in England. It would have to come from an.
I don't think you can do it now.
No,
you can't do it now. This is 6 years ago. So
yeah. And it's and you have to have failed every other possible treatment for spasticity, and you have to have a physio assessment. So it's quite a difficult thing to get hold of.
Yeah, I didn't need to do any of that, which was good. I'd
Yeah.
tried some of the clofenin and stuff, and it didn't really work. And my GP had said, I've known him for years and years, and he knows I'm not going to take, if it doesn't work, I'm not going to take, I hate taking medication. I always have done, always will do. And he knows that if I wasn't going to take it, if it wasn't going to work, I just wouldn't take it. And I cannot stress the difference that it made to my life. Absolutely a phenomenal difference. And I can take it just as and when I need it. I don't need to take it in case I have a spasm. I just take it when the spasms start.
And that's the difference with the other treatments, is that you have to take them every day, all day, every day, don't you, in order to try and get some benefit. And they all have very difficult side effects in terms of making you feel drowsy and knocked out, and it's quite hard to balance, you know, getting benefit from not getting side effects for all of those treatments, isn't it?
It is. And also the spray, it doesn't make you stoned, you know.
No.
You know, some people say, oh wow, you must, and you don't get stoned. You take a spray, you take 2 sprays if it's really bad, and it gets rid of the pain, and you're still able to function. You know, it's really quite, I just can't. And the balm, you can buy CBD balm, which is really good, and it's that again, fantastic. And it's
difficult from a pharmacy, from a drug licensing point of view, just to explain to the guys why we can't do clinical trials and license these products, is that the cannabis plant from which all these compounds is derived, and I can't remember the number off the top of my head, but it's something in excess of 300 different types of cannabinoid compounds in the cannabis plant. So if you think about how controlled clinical trials are in terms of the quantity of a drug versus placebo, it's impossible to distill an exact amount of the exact compound that you need into a pill and make it effective. It is the combination of all the different compounds that make it effective, and therefore it's a very difficult thing to design a clinical trial for, which is why nobody's really successfully done it in a big way with the cannabidiol products. But I think people are working on it, and hopefully they'll come up with something that's a bit more accessible to people than Sativex is at the moment.
No, that is brilliant. The main thing you want is just to get on with your life. You don't want to get too much in the way.
That's it. You want to lead as normal life as possible. There's going to be, you know, there's days when you can't get out of bed. And I think the saying goes, if you see someone with MS out and about, they're having a good day. You know, because there's days when you're not able to even leave the house. There's days when you can't even get out of bed because your legs aren't working. I would also say that not everybody, well, most MSs don't even record how many episodes they have with the doctor. So the statistics might be slightly off there, because they know that, you know, what it is. They know what's happening, and sometimes they will just stay in bed and see it through themselves.
You're absolutely right. And I think there's a really good place for technology there, Amy. I don't know if you use any apps or anything, but there's a lot of people developing sort of patient-friendly apps that people can use to record their symptoms, because you're right, that people are so used to living with these things that they don't get report, they get underreported, and the MS teams really would like to know more and they get a 15-minute outpatient appointment once a year with the consultant to talk about everything that's happened, and it's just not enough.
No, and plus it's normal to you. The pain, the spasms, that's a normality. That becomes a normality, and you no longer see it as anything different. So when the consultant says, "Oh, how have you been?" it's always going to be, "Oh yeah, okay, you know, the usual," and that's it. You know, they don't usually, because the appointments to that are so few and far between. Chances are, and also memory problems, you've forgotten that you had 3 episodes. You know, you've forgotten. So unless you've written it down on a calendar, which nobody does because you feel so chronically bad that you don't bother, and the majority of people that I deal with MS in Fife, we don't go to the doctors because we know steroids are the only choice. of speeding up an episode. And I think people only go if you're having a really chronically bad episode. But as a rule, we ride it out, we stay in bed, we hope someone brings us chocolate, and we get through it. And that's what you do. And we don't record it. So
if
I've
anyone
seen the
has,
apps.
oh, sorry, I was just going to say, if anyone has any questions, feel free to put them in the chat. Feel free to keep going.
Nope, no questions.
Nobody wants to own up to any questions. Oh, there we go.
Do I only use sprays for treatment? I have got gabapentin, but I'm on a small dose at night time. And what else have I got? I've got something else. What's it called? That's a good memory one. Oh, the one you get for neuralgia. What's that one called?
Can't think of it.
For trigeminal neuralgia, is it carbamazepine?
That's the one. Yes. So that as well. But that's all the ones that I'm on. I'm obviously Tecfidera for the disease modifying one. But I'm very small dose of everything. Because the spray actually does everything that I need it to do. Am I on my own?
So just to clarify for Aisha, the spray, you spray it into your mouth, right?
Yeah, under your tongue.
Yeah, under your tongue, and then that's absorbed and relieves the symptoms from the spasticity. But it's the Tecfidera that's the disease modifying drug that's trying to slow down the progression of the disease. Yeah.
Mm-hmm. And the thing with the spray is you're not aware of it working. You're just aware that your legs and your arms aren't, that you're not spasming as much. And also that the pain it does work as a pain reliever as well. It does. I know that's it's not used for pain, but it does help with pain, because spasms as a rule are very painful. I should be really fit, because the amount of spasms I have, my muscles should be top notch, but they're not. I'm not liking that. It's not fair.
Do you have like a diary or anything that you could record on how you're feeling?
Well, I did start that in the beginning, but then I thought, it's so depressing writing in it. Yeah. Really depressing, because you realise you're ill. You try to pretend you're not ill, and then you've got to write it, and you're like, oh God, my God. And the other thing is having to put friends off because you want to go out, but you can't go out. I mean, my bedtime is 7 o'clock at night, and that's late, 7 o'clock in the evening, because by that time I don't work. I just stop working completely. Everything stops working. And it's the old thing about, someone mentioned about fatigue. I don't know if you've heard an analogy about spoons, the spoons analogy with chronic pain and chronic disabilities. It's where your energy is spoons, and everybody can have, a cup of coffee and a rest to regenerate their spoons through the day. With MS, you wake up with 12 spoons, and that energy has to last you the entire day. And each activity uses different amount of spoons. So getting up, that in itself is at least 2 spoons. And that's not even before you get dressed and you've got to wash your teeth, you've got to wash for a man, you've got to shave, drying your hair, showering. So before you even leave the house, you've probably used about 5 spoons. You then go through your day. And when I go out to schools, I'd have my spoons with me, and I get the kids to shout out what they do. By lunchtime, they've used all their spoons. And so they say, what do you do? What do you do? And I say, right, okay, well, you can borrow the spoons from the next day that you need to get through to the end of the day. So you've borrowed from the next day, but then the next day, you don't have as many spoons to start with. And when this continues, you run out of spoons. And that's when usually you have called an episode, because you're absolutely wiped out and cannot move.
So someone's asked about how you cope with fatigue, Amy. I'm going to have to go shortly, but I just wanted to say it's I did say that it's one of the areas where we just don't have any drugs that help. You're right, Amy. People like to offer drugs to patients all the time because it's the only thing we feel that we can do is to offer you some medicine. We can't give any medicine for fatigue. There was a clinical trial reported at the last MS conference where somebody had compared all the different drugs that have been tried for fatigue with placebo, and none of them were any better than placebo. The only things that have actually been proven to work are CBT, cognitive behavioral therapy, and exercise, high intensity, but you have to keep up with the CBT and the exercise all the time to get the benefit. And as soon as you stop doing those things, the benefit goes away. So it's quite hard work, isn't it? Having to do exercise in order to combat
exercise. It's not going to do the exercise.
No, exactly. It's quite difficult.
I'm a behavioral scientist. That's what I do. Well,
right.
I used to do. So CBT was my big thing. I used to do that. I used to do it with young offenders, however. But with actual proper fatigue, you don't do anything. There's nothing you can do with it, but you've got to make sure you don't get into the routine of not doing anything, because you still have to try and get up and you still have to try and keep going, because there's the old school where that if you're fatigued and you take to your bed and you stay in bed, it makes it harder to get out of bed. So you've got to keep going as much as you can, and you've just got to rest. That's all I can advise, is you've got to listen to your body, and you've actually got to, when it says stop, you've got to stop, because if you keep pushing, you're just going to do harm. I saw some other questions, but I couldn't see them. You'll have to read them out to me again.
Rachel's just leaving, so thank you, Rachel, for coming today. It's been brilliant. I think everyone's got a bit of benefit from this. Amy, if you're all right, will we just finish the questions?
Questions. What were they? There was some there.
So, how would you describe how MX affects the... hundreds of people are typing. I've lost the question. Sorry. How would you describe how MX affects the family and friends of kind of MS patients, and how can we kind of best support an MS patient?
I think the worst part for families is seeing the pain that someone's in and feeling completely unable to help them, because there is nothing they can really do to help them. And also, my husband, the other part is your significant other. They then become your carer, so you go from being lovers to carers, and that's kind of like weird, because not to beat about the bush, but when in the shower, when you might have been raunchy, now you're in the shower and he's washing you, that kind of thing. And that, it does affect the psyche, it does affect how you see yourself, and your perceptions on how your significant other sees you. You then you've got to worry about your children, because they give up so much. My children have given up so much to look after me. And it's heartbreaking to see, for them to not be able to help. And for me to be able to, I want to say to them, don't pick me up because you're going to damage your backs, because I'm not exactly little, So, luckily they're 18 and 16 now. But telling them not to lift me off the floor and to go and get their dad, or go and get the neighbour, or go and get, a nice fireman would be nice. So anyway, I digress. But trying to get someone who can, and for them to see you in pain, it's not nice. And for them not to be able to help, it's a feeling of helplessness, as, from what my family have told me, they feel helpless, they can't do anything. And then they can get angry, especially with children. They got a bit angry because it's not fair. Why their friends' mums can do this, their friends' mums can do that, but you can't. So it's how best you could support them. If young carers, refer them to organisations. The young carers are brilliant. They have been fantastic at being able to just say, you know what, you're not alone. come here, we'll take you this place and we'll do this. We'll go, both my son and my daughter, they went yachting. Is that what you call it? Sailing on a yacht on the West Coast. But that gave them time to be themselves. They didn't have to worry about me because they knew I was being looked after, and they could just completely be themselves.
Yeah.
And you know, they do activities, and they've got support workers who they can talk to and say, look, I'm feeling like this, I'm feeling a bit sad, and the support workers have been brilliant.
Yeah, definitely. I've seen it with my gran myself. I went to stay with her a week a couple of months ago, and I drove up, and it was things like she's got the wheelchair, she's getting the wheelchair in and out the car and helping her up and down, getting out the car, and you don't realise how much kind of goes into it. And she doesn't want me to be like that. She'll try and push herself up off the chair because she doesn't want me to help her.
Yeah.
My granddaughter. And it's a pride thing, but it's still like, it's okay. Like I knew what I was getting into going up and being there myself, but she still won't want to help. Do you need a hand with dinner? No, sit down.
Yeah.
It's I don't know, it's almost a pride thing, or maybe she's stubborn, but
it's completely a pride thing.
It's hard like that.
No, you don't want your kids, you don't want your grandkids, you don't want to be seen also by other people. You don't want the sympathetic looks. Oh my God, they're awful. Oh, it must be so hard for you. Shut up. You know, just treat me normal. Just talk to me like I'm normal. Don't talk to me as if I am MS. Talk to me as if I'm still the same person that used to go out with you all those years ago, drinking. And now don't treat me like I'm different because I've got MS, and people do.
Yes.
And that's hard to take.
Yeah.
There's another question which I can't.
Yeah, there's one more question. Do you think doctors could have provided you with more support, as you said, support groups, and your own research was more helpful?
The neurologist was useless. Can I put that out there? The registrar was very good in the hospital, but the neurologist, he was so, when I was in first time being diagnosed and everything, I'd had a really bad do, and I'd lost all sensation, and I actually physically felt myself get worse over the day whilst I was getting an MRI scan. Felt off. And they admitted me, and I went for a shower, and I had to walk with a Zimmer frame. Very unflattering. And as you all know, if you've been in hospital, those towels are not big. They're not big enough at all. They're like hand towels. And I'd been for a shower, and I'd wrapped it around myself very carefully, and I was like this, and I was shaking one of the symptoms of MS with my Zimmer frame. And I was walking closer to my bed, but my towel was coming down and coming down. And I finally get to my bed, and I just go, oh, and the towel comes out. Meanwhile, this was Dundee, by the way, teaching a hospital. Neurologist comes in with 1,000 students, right? And I'm sprayed out like this in my full glory of, it wasn't very pleasant. And I was like, and he was just talking. This is Amy. She is 34. Presented with this. And I'm sprawled out like a what's it called? A spatchcock chicken. So I'm like that, splayed out on the bed. And I'm like, oh my God. And I'm trying, and I don't know, the fatigue was there. Quite bad on this. I was trying to, and luckily one of the students, ever so nice, he came up and he went, do you want covered? I went, thank you. But the neurologist said, it was if he didn't see you as a person, you were a case. And they were going, what do you think we should do next? What test should be run? What test should be run?
Yeah.
And I was like, well, just cover me, a bit of dignity. So
yeah,
what I would say is that the neurologists especially, they need to be human. They need to not be robots. They need to not be textbooks just regurgitating all the facts. They need to actually see how it really affects you, how they could even pretend, they could say, oh yeah, it must be terrible, you must be feeling this, but they don't. And I think, but the GPs have been marvelous, absolutely fantastic. And they always say to me, well, that might not be MS, Amy. This might not be MS. And so, and they say, well, how are you coping with the pain? And they ask, how are you coping? How are you feeling? And I know that a lot of MSs are on antidepressants, but I don't know whether that's because the MS physically has caused the depression because of the chemicals in the brain, such like, or whether it's because of their lifestyles have changed so dramatically that they have. And that's when I would say that maybe they should look into, rather than medicating straight away, look into maybe going to a psychologist, maybe going to see.
Yeah, definitely. So just a reminder for everyone, I will share out the slides after this, and the recording will be going online as well. So just if anybody's having to leave, I've had a few messages, all the slides will be accessible and so will the recording. So don't worry about that. So that is all our questions. So thank you very much, Amy. I think a lot of people really loved the personal point of view, especially everything about CBD oil. I think this is important kind of for us to learn about this, and especially a personal point of view, how we can kind of fit in. Because even just that, if we're in community pharmacy, that simple, how are you feeling, how are you getting on, can make a difference.
It can be. And also just saying, are you part of a group? Knowing what groups are available in your area, just for simple, you know, a simple thing like that, you know, it makes a big difference.
Yes, so just a few things before the session ends from a kind of BPSA point of view. We do have applications now out in each area for liaisons and representatives. A liaison is more of kind of a head rep role. They kind of look after 4 reps in their university and kind of coordinate the promotion of the BPSA within the university. And the reps, they kind of promote BPSA material and attend events like that. Applications should be sent out to each of your School of Pharmacy with Google Forms to apply. The next area event is on Monday, which is the Western area on chronic respiratory disease management, and that is 8 till 10. The Eastern area have theirs on next weekend on the 5th of December on racial disparities in healthcare. So that's 10 a.m. till 4 p.m. And the Pennine area have improving autism accessibility in healthcare on the 12th of December from 8 p.m. to 10 p.m. So that's all. So thank you very much.
Thank you. Thanks very much for listening to my rantings.
We love the ranting. Perfect. Oh, sorry, 6 p.m. to 8 p.m, not 8 p.m. till 10 p.m. Just watching the numbers drop down. Just the last few people, I think. And breathe. No, that was really brilliant.
That's good.
Yes, thank you for coming along. It was a success.
That's okay. If anybody needs information about MS, I'm quite happy to speak to them, write to them, anything.
Yeah, I'm really happy. It's kind of went well, and it's kind of, we've gotten through it. Good turnout, that was the main thing. So yes, I'm over the moon. And now I can breathe. Might get a takeaway now, that's gone well. Hi, Alex.
Hi. No, there's only a few people left. I just wanted to jump on. Amy, thank you for sharing that. So I'm one of Joanna's colleagues, and honestly, listening to your experiences and your process through it has been really inspirational to hear. So thank you for giving us your time. And Joanna, incredible first conference. I think you should be really proud. I know how nervous you was for this, but honestly, really, really good, really, really strong conference. And I know
it was really good.
Yeah, and to have 100 people, over 100 people for the whole thing, that was absolutely incredible. So, Joanna, you've done yourself really proud. And again, thank you, Amy, for your time.
Yeah. Well.
So yeah, quite a few members of the BPS executive were here today actually. So it was good turnout from all of the exec and from all the unis in general. So yeah, my best friend is still here actually. Hi Fraser.
Hello, I don't know if I should say.
You can speak, it's fine.
Well,
So no, I'm really happy with the way it's turned out. I'm sure there'll be plenty of CPDs and stuff like that getting written up, and so yeah, that was the main aim. And loads of people now know about CBD and the Sativex spray. I'll be going and phoning my gran now and telling her to get that.
Get it. Tell her to get it. Do you know, but
she lives kind of in a remote area. She lives near Gaylord up north, and like there's not a lot up there. She can't drive or anything. So I'm like, even if she could just move easier
Yeah,
out of
to
the
grow
house,
her own.
makes a difference.
And she's a baker. She can make some nice brownies.
She used to have a bread machine and she used to make bread every week and soup all the time. And oh, session's being recorded. I saw